And it's lovely to have on the couch Carol Atmore. And Carol and I worked together on the West Coast eons ago, it feels like, and we're both incredibly young looking. I've no idea how we've managed it. It's brilliant. Carol, you've got two hats. Most importantly, you're a GP, but in addition to it, you've got a title of Chief Medical Officer for the West Coast. We could talk about all sorts of things, but just over the next 5 minutes, it'd be lovely just to talk about what exactly is happening in Grey Hospital, in particular with the fellows of the Division of Rural Hospital Medicine and how they're integrating with your, I was going to call them specialists, but I don't know what else to call them, the non-fellows of the Royal Hospital Medicine, but specialists in their own disciplines, and how that's going. So how's it going there?
Well, we're really getting into some interesting new territory, I think, for the New Zealand health system. I think it's where we're probably going to be going more with the smaller hospitals around the country that are bigger than rural hospitals, and Grey Hospital is either the largest of the small or the smallest of the large, whichever way you look at it. So last year we were able to get the scope of practice for rural hospital medicine doctors to be recognised as being able to work at Grey Hospital because they're working in a different way now than, say, 4 or 5 years ago.
Was that a problem to get that scope accepted by the Medical Council?
Well, it was with the branch advisory body of the rural hospital medicine faculty that we had. They came and looked at what we were doing and what we were proposing. So we're actually developing a model where generalists, which we're using that term to describe the rural hospital medicine specialists, but generalists and specialists are working together to provide traditionally specialist level services. So you probably may know for several years, John Garrett, our paediatrician, has been providing paediatric services, and fantastic paediatric services, using coming over to the coast for a couple of days, a fortnight, and also using video conferencing into the paediatric ward to provide paediatric services at a distance with support on the ground from one of our general physicians who's done paediatrics for years. But he's near retiring, and we're thinking how we're going to make this model sustainable. So our rural hospital generalists, or the terms start to get confusing, yes, are working with John's support, providing the overnight cover when Paul Holt isn't available, the physician who's done it for years, and with the view to the future being that the generalists are on the ground with the nursing staff video linking through to the paediatrics specialists in Christchurch. So that model works really well.
So that's external specialist support. What about the fellows working with your resident specialists as well to sort of expand?
Yeah, well, so we've also got a similar model working with orthopaedics, and which again the orthopaedic surgeon is generally in Christchurch, and now we're looking at how we can develop that model with general medicine, using our general physicians on the coast being supported in the out-of-hours space with the generalist. So it's a new space. I think it's how things are going to go as we progress as a country. So there's obviously teething issues with that. We've got to make sure that it's safe, that we've got the scopes of practice are well defined, that we everybody is on board with the notion, so that we support each other when we hit teething problems.
Sure.
But
are you breaking new ground, or is this a wheel which somebody else has invented for you already?
Well, probably the difference is Ashburton use that model where they only have rural hospital medicine doctors, and their supports from Canterbury, from Christchurch. I think for the new ground is that we're quite a lot further away. Just occasionally you can't actually transfer the patient, and also we want to have specialists on the coast resident in the longer term, whereas Ashburton, the specialists have actually exited and they don't reside there, and I think we need a mixed model in the future because of the isolation factors. You can't be flying everyone in and out from Christchurch all the time, because sometimes they can't get in, and much to their disappointment, sometimes they can't get out.
So beautiful place to be trapped. So what problems are you hitting logistically to get it going?
Well, I think because it's a new idea for single organ specialists, yes, to be to be confident that this model where we've got the generalists and the specialists working together, that we can make that a safe system. Those are the things that we're having to design how we do it in such a way that we can test it and make sure that it is a safe system.
Is there a patch protection problem there, do you think?
I couldn't possibly comment.
Of course you can, that's why I've nailed you to the floor.
Look, I think it's a new thing, and some people like you and I embrace change. You're faster than me. But there are people who are, they're naturally cautious, and I think you need the balance, because the cautious people say, but what about such and such? So you go back and go, yeah, that's a fair point. Actually, let's make sure that we've covered that off. So,
well, to make it sort of less personal, I admit personalities do come into it. I was perhaps thinking more on a college basis. Are the college of surgeons worried about their patch protection? Are the college of physicians worried about? So have their respective colleges embraced this model?
I think that it hasn't really got up to the college level in terms of, because we're small, we're hard to staff, we've run on locum specialist doctors for years, the patch protection isn't coming into play. It's an interesting question when you think about saying, well, maybe this might be a model that might actually be used in other larger places in the future. Maybe that's when that issue might arise. But we're trying to just get it working with our team, and who are all members of their various colleges along the way.
And with the fellows of the Division of Royal Hospital Medicine, are they embracing it and enjoying it too?
Yes.
Great, so there's enthusiasm from that side of the fence.
Yeah, absolutely.
So from this conference's perspective, that's the right side to have the enthusiasm coming from, isn't it, really? So.
And the other thing is that we are, really wanting to develop our training for rural hospital medicine as well as GP training on the coast. So you can actually, the trainees, for example, can actually do 2.5 years of their training now on the coast for rural hospital medicine. Excellent. And we've got links with Canterbury for those parts of the placement that you can't do, like the A&E and the ICU and those kind of things, where people can go to Christchurch, have those runs sorted for them, and then in the hope that they might want to come back and play with us in the future.
I hope they do. And certainly we've got the video linkage as well, and is the broadband rollout working in your favour for that as well?
I know, and in Greymouth that things are fine. It's certainly for South Westland is where the speed of the broadband is the issue.
Kind of saying Haas is going to miss out, unfortunately. But Grey, you're right, in Grey Base anyway.
Yeah.
Well, look, I have certainly thoroughly enjoyed working on the coast, as you know, and if ever you want anybody to plug it, I will for you. I'll be your man. I so wish you the best of luck with this, and I know you're going to give a presentation on it fairly soon, and I know it'll go well. So thank you very much indeed for coming.
Cheers, Buzz.
Thank you.
Thanks.